Hi everyone. Today I want to talk about something that made research oncologists cry, literally. And I mean that in the best possible way. I'll be talking about a new drug called daraxonrasib, a targeted therapy showing remarkable results in pancreatic cancer. We'll be talking about a news article published by the Associated Press on NPR on May 31st, 2026, titled Experimental Pill Promises New Hope for Deadly Pancreatic Cancer, and comparing it to the original research study it was based on, a Phase 3 clinical trial called RAS Salute 302, published in the New England Journal of Medicine. My goal is to evaluate how accurately the news covered the research and what it all means for nursing practice. Pancreatic cancer is one of the most feared diagnoses in medicine, not because it's the most common, about 67,000 Americans will be diagnosed this year, but because of what it means for survival. Only 13% of people with pancreatic cancer are alive 5 years after diagnosis. For those with metastatic disease, cancer that's already spread, we're talking months, not years. On May 31st, 2026, the Associated Press published an article on NPR titled Experimental Pill Promises New Hope for Deadly Pancreatic Cancer. The article reported on results from a major clinical trial presented at the ASCO conference and simultaneously published in the New England Journal of Medicine. To understand the research, we first need to understand what's being targeted. Over 90% of pancreatic cancers carry a mutation in a gene called KRAS, K-R-A-S. KRAS normally acts like a light switch for cell growth, on when needed, off when not. In pancreatic cancer, the mutated version gets stuck in the on position, permanently driving tumor growth. So why does this matter to us as nurses? Because pancreatic cancer patients don't just interact with research oncologists, they interact with us. We assess their pain, we manage their symptoms, we administer or educate them about their medications, and we advocate for their quality of life. When a new treatment changes how this disease is managed, it changes our practice too. Understanding the evidence behind emerging therapies is a core nursing responsibility. For decades, science called KRAS undruggable. The protein's shape made it nearly impossible for drugs to bind to it. Daraxonrasib works like a molecular glue. It binds to multiple subtypes of the mutated KRAS protein simultaneously, locking them down. It's a fundamentally new mechanism in cancer treatment. FAME criteria I, the sample. The target population is clearly described. Adults with previously treated KRAS mutated metastatic pancreatic ductal adenocarcinoma. Inclusion criteria required confirmed RAS mutation status and prior treatment failure. The multi-center international setting of approximately 500 patients across many countries strengthens external validity through variations in chemotherapy choice across sites could affect the comparison arm. In the FAME criterion G, the operational definitions, the independent variable is clearly defined. Daraxonrasib, 300 milligrams daily by mouth versus investigator choice chemotherapy. The primary dependent variables are overall survival, time from randomization to death, and progression-free survival, time to disease progression or death, both assessed by blinded independent central review. In FAME criterion K, the data collection instruments, survival endpoints were assessed using blinded independent central review, a validated objective method that reduces measurement bias. The quality of life was measured using standardized patient-reported outcome instruments. These are appropriate and validated tools for an oncology trial. The results. Patients on daraxonrasib lived a median of 13.2 months. Those on chemotherapy lived a median of 6.7 months. The hazard ratio was 0.40, meaning at any given time, patients on daraxonrasib had a 60% lower risk of dying. This is an extremely strong statistical result. Many patients were still on treatment when the data was collected, meaning the survival gap may widen further. Quality of life scores also favored daraxonrasib, and patients reported less pain and better function. Overall, patients that were taking daraxonrasib lived on average twice as long as those on regular chemotherapy. Now let's evaluate how accurately the NPR article represents this research. Overall, it's a responsible and mostly accurate, but with specific things worth examining. The headline says, quote, promises new hope. The word promises overstates certainty. The drug hasn't been FDA approved yet. That said, the article quotes Dr. Wainberg directly saying, while not curing the cancer, it is a very large step forward, which appropriately does temper expectations. In another point of the article, it is quoted as saying nearly doubled survival time, which is technically accurate. 6.7 to 13.2 months is close to double. However, the article doesn't adequately contextualize what 13 months means. This is an extension of life in a very sick population, not a cure. And because this is a randomized controlled trial, the drug actually does cause the improvement. Randomization ensures the groups were equivalent at the start. So what's missing? The article mentions rash and mouth sores, but doesn't note that 30% of patients had a grade 3 or higher adverse event. It also doesn't mention the open label design as a limitation and data that weren't yet mature when the article was published. Using FAME Table 15.2 framework, which organizes critique around problem statement, research methodology, results and conclusions, we can identify two strengths and two limitations of this research. Strength number 1, research methodology or design. The Phase 3 randomized controlled trial design is the gold standard for establishing causal relationships between a treatment and an outcome. The International Multi-Center Design, Blinded Independent Central Review, and pre-specified dual primary endpoints all reflect methodological rigor. So why does this matter? The stronger the design, the more confidence nurses and clinicians can have when applying findings to practice. An RCT gives us much stronger evidence than a cohort study or case series could. Strength 2. Results, conclusions, and interpretations. The findings are statistically robust, as previously mentioned, and clinically meaningful. The dual primary endpoints of both overall survival, OS, and progression-free survival, PFS, are the outcomes patients and clinicians care about most. Quality of life data adds further clinical relevance beyond survival alone. Limitation number 1, the research methodology. The open label design means neither patients nor investigators were blinded. This is unavoidable when comparing a daily pill to IV chemotherapy, but it can bias self-reported quality of life data. Patients who know they're on the experimental drug may report feeling better, partially due to expectation. Limitation 2. The sample and results and conclusions. The study enrolled only patients with RAS-mutated, previously treated metastatic pancreatic cancer. This covers the largest group, but doesn't tell us how the drug performs earlier in the disease course. Additionally, data are not yet mature. Many patients were still on treatment at cutoff, so the full survival picture is incomplete. Generalizations beyond the studied population are not yet warranted. So, what do we actually do as nurses with this evidence? Daraxonrasib is an oral targeted therapy, a daily pill, not an IV infusion. This fundamentally changes the nursing role. With chemotherapy, nurses manage IV access, infusion reactions, and intensive clinic monitoring. With an oral agent, the patient self-administers at home. The nursing role shifts to adherence support, telephone triage, and remote symptom management. The side effects of daraxonrasib requiring nursing attention are rash, which can escalate to severe, and oral mucositis or mouth sores. Nurses must assess these at every encounter, intervene early, and recognize grade 3 escalation that may require a dose hold. Nurses also need to help patients understand what this drug is and what it isn't. It is not a cure. It extends life and improves quality of life, but setting realistic expectations is compassionate, not discouraging. Medication adherence matters. Missing doses of an oral agent can reduce efficacy. Patients need to know when to call: fever, severe rash, or the inability to eat. Is this evidence strong enough to recommend changes in practice? Yes. With the studied population, a Phase 3 RCT with a hazard ratio of 0.40 meets a high bar. The FDA has granted expedited review and expanded access is already available. For healthcare policy, this drug will raise important access and equity questions. Targeted therapies are typically expensive. Nurses and advanced practice nurses advocating for patients will need to understand what assistance programs exist. Insurance coverage will be critical, especially for underserved populations who already face worse pancreatic cancer outcomes. Daraxonrasib represents a genuine breakthrough in a disease that has resisted treatment for decades. The research is rigorous, the results are statistically and clinically significant, and the nursing implications are immediate. The NPR article captured the spirit of the findings, but left out important nuance around side effects and study design limitations. As nurses, our job is to bridge that gap to translate research into informed, compassionate care for our patients. Thank you.